Now we'll go to the industrial spot and by Y4, I think, as be presented by my colleague and friend, Dr. Omar Hallak. Dr. Omar is one of our senior intervention cardiologists and from King's Hospital. Dr. Omar has been here in many years and expert in the whole cardiology. Of course, heart failure is one of the area. And this is iron deficiency, which we don't know iron deficiency anemia. It seems, this is the things we are missing. And today, Dr. Omar will take us through the iron deficiency and iron deficiency anemia, an overlooked aspect in the management of heart failure with recent data. Dr. Omar, we're looking forward to your topic.
You're muted.
Assalamu alaikum. Thank you, Dr. Abdullah, for the nice introduction, and I'd like to thank the organizing committee for the invitation, and especially Y4. As you said, this is another issue which can be associated with heart failure and hopefully potential benefit of heart failure if you fix it. The iron deficiency anemia. We don't, cardiologists, many times look at it in particular because we're busy about proBNP and electrolyte and so on, but tend to be that looking at the ferritin level and saturation level and looking for iron deficiency anemia and treating that one with IV iron can improve the quality of life of patients with heart failure. And that we're going to concentrate in my talk about the quality of life of patients with heart failure who have iron deficiency anemia and treated with IV iron. You can see my slides, right?
Yes. Just make it bigger.
Okay. I think we'll go from beginning here. Iron deficiency anemia is common in heart failure. 50% of patients with heart failure have iron deficiency anemia. And then it really doesn't matter what the ejection fraction. It's common, 50% almost, in patients with reduced ejection fraction, mildly reduced ejection fraction, or preserved ejection fraction. So across the board of heart failure, they have iron deficiency. And this is interesting that iron deficiency reduces exercise capacity regardless of anemia. So here, and here is a big VO2, and this patient have anemia, but no iron deficiency. And compared to somebody have iron deficiency, but no anemia, there is more impact on their exercise capacity. And here is also affecting quality of life. Here the patient with iron deficiency, the overall quality of life is getting worse with iron deficiency. Here is no iron deficiency. And here also the physical quality of life significantly affected by iron deficiency. If you look at the anemia per se, there's not really much difference between the two groups, anemia and no anemia. It also affects the survival. Out of the cohort study of 1,500 patients with heart failure, iron deficiency anemia increase the mortality. Here's the patient without iron deficiency anemia. Here's the patient with iron deficiency anemia. Over 8 years period, the one with iron deficiency anemia, they have higher mortality. And again, this is patient have no iron deficiency anemia. No iron deficiency, but they have anemia. And this patient have iron deficiency, but no anemia. And turned to be, it increased the mortality rate in patients with heart failure. There's some trial on IV iron replacement with FCM, ferric carboxy maltose, and there's quite a few studies here. We're going to look at some of the study about the replacement of iron in patients with heart failure and iron deficiency anemia. Ferric carboxy maltose in patients with heart failure and iron deficiency. This is published in New England 2009, and the results showed at week 4, 12, 24, overall patient quality of life score, New York class for heart failure, and 6-minute walk, all improved after IV ferric carboxy maltose in those patients. Also, quality of life score also improved using the Kansas City quality of life score. Another study confirmed heart failure, and this is the benefit of long-term intravenous IV iron supplement therapy with FCM in patients with symptomatic heart failure iron deficiency, published 2015, improved the 6-minute walk, New York classification for heart failure, fatigue score, and Kansas City cardiomyopathy quality of life score, and decreased hospitalization. Another study, effect of FCM on iron deficiency in patients with heart failure, meta-analysis published in 2017. The results showed that FCM improved cardiovascular hospitalization, all-cause mortality. Another study, effect heart failure, published in 2017, the effect of ferric carboxy maltose on exercise capacity, and the results showed that improve giving the IV FCM, improve oxygen consumption, improve in New York classification, peak work rate, and patient global assessment score. Now, this interesting study that you giving the iron orally, it was negative result. Actually, this published in JAMA in 2017, patient with heart failure and iron deficiency anemia, for whatever reason, giving the oral dose did not improve the peak FVO2. Ongoing study, the latest one we have here, because there's still some ongoing study, we don't have the result, but this one published in November 2020, affirm acute heart failure study, and the study on ferric carboxy maltose for iron deficiency at discharge after acute heart failure, multi-center double-blind randomized controlled trial. They have about 1,500 patients with heart failure admitted to the hospital with decompensation, stabilized, and after stabilization, about to be discharged, randomized to giving iron supplement IV, FCM versus placebo. And that was given the day 0 of discharge. And then I'll show you the protocol here, given at week 6, and some of the patients giving at week 12 and 24. Not all of them, it depends about their iron level. So we have a 1,500 patients stabilized after treated for heart failure, and then about 560 giving the supplement, and the other one giving the placebo. The baseline characteristic, mean age about 70, ejection fraction about 32, and hemoglobin about 12, ferritin 83, and transferrin saturation about 15%. 80% of them, they have less than 20% saturation. And this is a result. The primary endpoint, total heart failure hospitalization and cardiovascular death, and there is about 21 relative risk reduction between the group of the treated group versus placebo group. Understand the P wave is kind of borderline. And here, if they use hospitalization only, we have more impact, 26% relative risk reduction between the treated group versus placebo group with the stronger P wave. The death did not show significant difference between cardiovascular mortality. So it appears to be only improve the decrease the risk of hospitalization. If you have a subselection group, all of them, of course, most of them cross the line, but all in the right side of FCM. Here is all the different variables of those patients with heart failure. Same thing if you look at another variable variable, all of them kind of on the right side of FCM. In particular, this one, if you have significantly decreased ferritin, you have much more, of course, obviously, impact on the outcome. Adverse effects were similar between the two groups. Now, the impact of IV ferric carboxymaltose on quality of life, health-related quality of life, and that's kind of my mostly of my talk. And they ask questions about what is the most important things in the treatment of heart failure, and about 2/3 of the patient, they said they want to have better quality of life. Of course, the mortality and other things variable are important, but the quality of life, that's what the patient is looking for. They ask the doctor, what do you think the important things? And they have very similar answer. About 2/3 of them improve quality of life. And that's, of course, most of the diseases we treat is to improve the quality of life, and some of them to aim for extension of the life, but almost always the quality of life is the number one thing we do to treat, to improve. And here is iron deficiency comparing with this quality of life measurement. If the patient have no anemia but iron deficiency, they have worsening of their quality of life. Then patient have anemia but no iron deficiency. Physical factor, the quality of life, it can look at the global quality of life, physical quality, health-related quality of life, and emotional. And appear to be for iron deficiency anemia, if it's treated, if the patient have it, they have more physical decrease of their quality of life. This is a Kansas City Cardiomyopathy questionnaires, and they have a lot of things in their questionnaires. There's a physical limitation, symptom frequency, social limitation, and quality of life, and they score it between 0 to 100, poor, fair, good, and excellent. And here they look at the disease itself, the myocardial injury, and RAS activation, and the degree of LV dysfunction, the symptoms, fatigue, dyspnea, edema, and the functional limitation, physical, emotional, social, and then the quality of life overall, which is the discrepancy between what the patient have and what actually have. And they have something they call clinical summary score, combining between the symptoms and the functional limitation, and they have something called overall summary score, which is adding on the domain of quality of life. And back to the study we have earlier, affirm acute heart failure, patient stabilized, admitted to the hospital, about 1,500 patients hospitalized, stabilized, and before discharge, they classified to, they randomized to iron treatment or placebo and the first dose at the day of discharge. And they have the Kansas City Cardiomyopathy quantification for quality of life. Same as I said earlier, half of them in this analysis, and the other one is a placebo and other analysis. And this is what they found. What they found is there is, as I said earlier, the overall summary score, and this is what overall summary score. There is some improvement of the overall summary score on the patient treated with iron, IV iron, FCM, and also clinical summary score, also some minimal improvement, some improvement in the quality of life. At the end of the day, whatever we can add on to the quality of the life of the patient, we'll take it. Whatever, even small amount of anything can improve the quality of life. Of course, if it's simple and not very expensive, of course, we have to add it to the list of the patient. Here, if you look at a different curve, and this is the bottom curve is the one placebo, and the top curve is the patient receive iron, IV iron, for iron deficiency anemia, and this is where the amount of improvement of their quality of life, overall quality of life. And then if you look at the clinical quality of life summary of score, there's also improvement. There tend to be kind of narrowing down further down. Actually, the treatment was most of the patients only given one dose at discharge and one dose at 6 weeks, only a small percentage given at 12 week or 24 weeks. In conclusion, patient was established, patient stabilized after acute heart failure episode with concomitant iron deficiency. Health-related quality of life at baseline was severely decreased. Following discharge, patient experienced initial improvement in health status, regardless of whether they're given FCM or placebo. Compared with the placebo, patient treated with IV FCM demonstrates significantly greater improvement in their quality of life status at 4 weeks and up to 24 weeks. As I said, 20% of patients only given a dose IV on 12 and 24 weeks. Attenuation of the treatment effect was seen at 52 weeks, and responder analysis revealed that a greater proportion of patients in the FCM arm had a clinical meaningful improvement in the Kansas City cardiomyopathy quality of life measurement, which was for 12 week and 24 weeks compared to placebo. What do the guidelines said about this iron deficiency anemia patient with heart failure? The guideline, European Society of Cardiology guidelines, they said you have to measure the iron level, measure saturated, transferrin saturated level, and treat. And also 2017, American College of Cardiology, American Heart Association, also they have somewhat similar recommendation is to have to assess the patient, and in addition to assessing the electrolyte and kidney function and other things that need to assess the presence of iron deficiency. And this is 2016 guidelines, but the 2021 European Society of Cardiology guidelines on treatment of acute and chronic heart failure, what they recommend is management of iron deficiency anemia with ferric carboxymaltose in patients with heart failure, of course, the one who have iron deficiency. Periodic screening for iron deficiency and the use of ferric carboxymaltose to reduce hospitalization rate and improve heart failure symptom is recommended. And so it is a 2021 European Society of Cardiology guidelines. It's class 1 indication to check for iron deficiency anemia, ferritin level, and transferrin saturation, and also to IV treatment for patients who have deficiency is a class 2A, patient who have ferritin less than 100, or if they have between 100 to 190, but the saturation less than 20, is to give the IV treatment. Kind of interesting here to say that it's the erythropoietin patient with heart failure anemia is not recommended. It can be harmful. In conclusion, patient with iron deficiency stabilized after episode of acute heart failure, treated with FCM related to placebo, reduced the risk of combined endpoint hospitalization and cardiomortality death, and mostly was on a decrease of hospitalization, and there was significant improvement of the decrease of hospitalization, and also decrease the quality of and improve the quality of life. So the treatment was well tolerated without significant side effect compared to placebo. Thank you so much.
Thank you very much, Dr. Omar. You know, I think it's very, very important. I mean, I've for the last 6 months, my eye-opening to this, and I've been doing looking at the iron deficiency, anemia, and the heart failure patients. And when it started, I think the screening is very important. That's what the guideline says, recommended class 1. Then comes the management. Of course, the management are many ways, but if you have the treatments available, although, for a long time we've been waiting for what is going to help our acute exacerbation heart failure. What we've done for the last 30 years, nothing changed. But I think this medication has got, at least on the hospitalization, is really remarkable. And I've seen it also in quality of life. I don't know if you guys tried this in your patient with heart failure, this medication, and you've seen it yourself. I'm rather away from what the study says. Anyone got experience here? Dr. Tfadal.
Thank you for the lecture. I am little surprised that they gave IV iron to people with hemoglobin above 12. Usually, you consider that a very, very mild anemia, and you don't give IV iron. So what is your thought about that?
So Omar, you want to answer that?
Well, interestingly, of course, they give it to the patient who have iron deficiency. I mean, the patient have normal hemoglobin, but their ferritin level less than 100. So they give those patients the iron. And yeah, it's not common to give iron supplement if somebody have a normal hemoglobin, but they measure the ferritin, and the ferritin was low and saturation was low, so they give the ferritin to replace that deficiency. Apparently, the iron have much more effect on the heart cell than just increasing the hemoglobin. Of course, hemoglobin is transmitted or a vehicle for moving the oxygen, but there may be some other benefit of iron or physiology of the iron affecting the heart function and the other function, including the muscles and also some enzymes required iron. So anemia alone is important, but probably iron is also very important.
I just would like to make a comment on this. We have a treatment right now for iron deficiency, and as commented, the problem right now is to test patients. So in our national register on heart failure in Sweden, we test how many patients get tested for iron deficiency over the last 2 years, and this was only 27% of patients with heart failure, which is extremely low. And of these patients, basically, only 17% of them got ferric carboxymaltose. So basically, yesterday we have been talking about under-treatment of patients with heart failure with reduced ejection fraction, and when we talk about underdosing and under-treatment, we should consider also what happened with ferric carboxymaltose, which is actually undertreated. Although there is no effect on mortality in clinical trials, we should not forget that in many patients, in particular in those who are older, the improvement of symptoms and quality of life is a priority.
Beautiful comment. Dr. Sharif Bakir, please come join us here. Thank you, Dr. Omar, for the session. Thanks to Vifor for supporting this meeting. We'll now move to our final session of tonight, and my two co-chairmen here, Dr. Sharif Bakir, all of you know, senior consultant, been in different places. I don't know where the last place, but is one of the highly educational in the field of heart failure. And really nice to have you with us, Dr. Sharif, and Prof. Rosano, of course, with me in this session. So the session is about comorbidities, and I'll let my colleague, Professor Rosano, to introduce the first speaker.
So the first talk is from